Standard clinical algorithms treat chronic constipation as an isolated plumbing problem, but pushing more material through a failing system eventually hits a rigid barrier. Under the Rome-4 diagnostic criteria, chronic functional constipation, or CFC, is classified as a gastrointestinal disorder completely devoid of structural or organic lesions. It is a significant clinical burden, affecting roughly 14% of the general population worldwide. The standard first-line therapies mandate increased fiber intake, aggressive hydration, and chemical laxatives. Yet for millions of patients, these motility-focused protocols fail to resolve the chronic, difficult defecation. Looking closer at these therapy-resistant patients reveals a persistent, overlapping comorbidity: chronic, nonspecific low back pain. The consistent failure of dietary protocols, coupled with the high rate of comorbid back pain, suggests that the physiological dysfunction may not be contained within the gastrointestinal tract alone. To understand CFC, the condition must be evaluated as a systemic lumbopelvic myofascial dysfunction. The human gut operates as a dynamic organ, suspended within an interconnected fascial web. The entire lumbopelvic musculoskeletal region serves as the critical structural anchor holding these visceral organs in place. By synthesizing three distinct clinical methodologies, dietary tracking, ultrasonic imaging, and pressure algometry, we can construct an accurate biomechanical model of this gut fascia axis. Resolving CFC requires moving past the digestive lumen to map the structural integrity of the surrounding core architecture. The investigation begins by testing the baseline assumption that poor diet is the primary driver of functional constipation. Researchers deployed a food frequency questionnaire to compare the daily intake of 100 patients diagnosed with CFC against 100 healthy controls. This chart shows the daily fiber and vegetable intake between the CFC and healthy cohorts. The consumption levels are near identical, yielding non-significant p-values of 0.163 for fiber and 0.245 for vegetables. The data diverged when the researchers shifted focus to lifestyle factors using the International Physical Activity Questionnaire. This compares physical activity between the groups. The large blue segment shows CFC patients have a significantly higher proportion of low physical activity. Conversely, the green and tan sections reveal the CFC cohort lacks both moderate and high activity. A highly sedentary lifestyle physically deprives the gut of necessary mechanical stimulation and degrades abdominal muscle strength. The dietary data eliminates food as the primary differentiator, while the physical activity data points heavily toward a mechanical and musculoskeletal deficit. The most common musculoskeletal hypothesis for CFC isolates the problem to the pelvic floor, suggesting that localized muscle hypertonicity prevents the sphincters from relaxing. To test this, researchers used transabdominal ultrasound, a non-invasive imaging method that tracks pelvic floor mobility in real time. This ultrasound technique precisely measures the displacement of the bladder base while the patient performs a voluntary pelvic floor contraction. The clinical expectation is straightforward. If isolated pelvic floor hypertonicity is the sole cause of CFC, the bladder base displacement should be drastically restricted in the patient group. This schematic shows ultrasound trial results measuring bladder base displacement. The CFC group averaged 1.88 millimeters compared to 2.62 millimeters in the healthy cohort. Despite the slight visual reduction, statistical analysis yields a p-value on 0.10, meaning the difference is not significant. A strictly localized view of pelvic floor dysfunction fails to fully explain the pathology of chronic functional constipation. Evaluating the condition accurately requires examining the entire global myofascial system of the core. Researchers utilized pressure algometry to map the presence of myofascial trigger points across the abdomen and the broader lumbopelvic region. They recorded the incidence of these hypersensitive trigger points, comparing the 100 CFC patients against the 100 healthy subjects. This matrix compares trigger point prevalence. CFC patients demonstrate over 50% impairment across multiple core muscles, standing in stark contrast to the control group's single-digit rates. The impact is severe in muscles like the rectus abdominis and quadratus lumborum, all returning extreme p-values under 0.001. The scale of this dysfunction extends far beyond the pelvic bowl, actively infiltrating the gluteals and the anterior abdominal wall. This widespread tenderness is not a sign of isolated weakness. It is the footprint of chronic, systemic muscle tension. The clinical data identifies a massive systemic upregulation of lumbopelvic myofascial trigger points as the primary differentiator in CFC patients. There is a direct anatomical mechanism connecting these distant lumbopelvic trigger points to localized bowel symptoms. The internal organs are wrapped and supported by the endopelvic fascia, which is an integral component of the deep frontal fascial line. This models the fascial architecture, mapping structural continuity from the pelvic floor up through deep lumbar muscles, attaching to the anterior abdominal wall. Tension along this sector exerts a mechanical force that physically encroaches upon the bladder wall and alters the anorectal angle. This continuous vector of strain directly mimics the symptoms of outlet delay disorders and prevents normal visceral mobility. Prolonged tension in the lumbopelvic musculature creates a rigid mechanical cage around the gut, establishing CFC as a distinctly biomechanical condition. If chronic functional constipation is a biomechanical disorder, a targeted mechanical intervention should resolve the clinical symptoms. Osteopathic visceral manipulation, or OVM, is a specific manual therapy designed to address and release this abnormal fascial tension. In a randomized controlled trial testing this method, osteopaths performed precise superficial and deep fascial release over the small and large intestines. The trial population consisted of 76 individuals actively suffering from both functional constipation and chronic nonspecific low back pain. These charts track outcomes for pain and physical disability. After 6 weeks of OVM, the experimental group shows a sharp downward trend. Improvements are statistically significant compared to the control, returning p-values under 0.0002 for pain intensity and 0.01 for the disability index. Physically manipulating the visceral fascia yields measurable improvements in both pain reduction and physical function, successfully validating the mechanical link between the spine and the gut. Analyzing the success of the clinical trial explains exactly why abdominal manipulation resolves both back pain and functional constipation simultaneously. Restricted, tense visceral organs generate excessive afferent neural input that travels directly from the gut back to the central nervous system. This schematic shows those nerve pathways. OVM improves the mechanical mobility of the viscera and releases the fascial tethering, which interrupts that stress signal. As these calmed neural signals enter the spinal column, they trigger a downregulation of excitability at the spinal level. This reduction in excessive neural traffic allows the body to restore normal paravertebral muscle activity during the basic flexion-extension cycle of the spine. Through this single neural mechanism, the bowel is freed from its mechanical restriction, and the painful, tense band in the lumbar spine is neutralized. The gut does not operate in a vacuum. It is inextricably suspended within a dynamic fascial web that dictates its function. Effective long-term management of chronic functional constipation demands moving beyond the internal plumbing of the gastrointestinal tract to restore the structural integrity of the entire lumbopelvic myofascial system.